What we're going to talk about is the parathyroid gland. The parathyroid gland are four glands basically situated on back of the thyroid gland, hence the name parathyroid. Now normally the parathyroid gland is responsible for releasing a very, very important hormone which is referred to as PTH, parathyroid hormone. Parathyroid hormone is responsible to regulate our calcium levels. Normally calcium, of course, within our body, 99% of calcium is basically going to be inside of bone. Only 1% of calcium is actually going to be in our plasma. Now, out of that one small percent of calcium within our plasma, 50%, 40% actually is going to be protein bound, specifically to albumin. 10% is going to be anion bound, for example, phosphate, and only 50% of that is going to actually be what is referred to as free calcium. And it's very important to understand that this free calcium, which is able to have effects on different tissues that we're going to discuss in a second, and it's this free calcium which is able to go and have negative and regulate PTH secretion. Okay, now normally calcium is extremely important for really three things. The first thing it's very important for is the central nervous system. You see in neurons, normally there are these certain sodium channels, which of course during depolarization are responsible for bringing the sodium influx into a cell. Now normally to regulate this process, what happens is that calcium, we have what is known as calcium caps, which basically sit upon these sodium channels to regulate how much sodium gets into a cell. In addition, calcium also provides in order for us to release vesicles. Okay, in order for us to release vesicles, in order to dock vesicles, we actually need calcium to go and bind with the vesicles so we can go properly and dock the vesicles. Okay, so this is very important for neurotransmission. It's very important for the pancreatic, different enzymes over there. So the calcium is very important over there. Of course, calcium is obviously very important within bone. And the fourth thing calcium is really for is for the muscle. You have skeletal muscle and you have smooth muscle. It functions in both skeletal muscle to help us move properly, as well as smooth muscles, specifically, especially within the GI system. Okay, so calcium definitely is very important. Now, in situations for whatever reason why calcium is going to be high, let's discuss the symptoms of hypercalcemia. Okay, hypercalcemia, of course, is when calcium levels are going to be very high. Okay, first of all, the first symptom you a lot of times are going to get normally because calcium is a calcium cap on the sodium channels. When we don't have this cap anymore, when we have too much cap now, what's going to happen is we're going to have much less depolarization, much weaker depolarization, and basically we're going to get CNS depression. Okay, and what degree of CNS depression? Of course, that always degrees on the how bad the hypercalcemia is. We could have fatigue, we could have coma, we could have lethargic, etc. Again, it all depends on how severe it is. Okay. Also, in addition, because it goes and affects the vesicles, although we're having a depressed state, we could also have sometimes these messed up depolarizations because let's say we're releasing vesicles too much, and this could actually even lead to seizures. In addition, because the vesicles are also going to be increased, the pancreas could actually increase all and actually release all its vesicles within itself, and this could lead to very, very important and acute pancreatitis. Okay, and that's also important to know. Okay, now regarding the bone doesn't really make a difference. However, the smooth muscle and skeletal muscle, again, because we have too much calcium, this could affect with the way the muscles work, and of course this could lead to muscle fatigue, it could lead to muscle weakness, and basically it could have to exercise intolerance. In addition, very, very important, because it affects the GI muscles, what happens is because this leads to GI contraction of the muscles, so what happens is we have too much contraction, then we're going to have decreased mobility within the GI system, therefore we're going to have the constipation symptoms, okay? Also, in addition, I forgot to mention before, calcium also goes and increases all the gastric secretions. So if we're going to have increased secretions, this could put them at risk for any type of peptic ulcers, okay? So that is hypercalcemia. Now regarding hypocalcemia, you really just got to switch it around. In hypocalcemia, what happens is, for whatever reason, calcium levels are going to be low. And when calcium levels are going to be low, the first thing you're going to have CNS excitability, okay? And specifically, this is referred to as tetany. Okay, tetany, of course, is the group of symptoms caused by and due merely to the fact that we have low levels of calcium, and basically if we don't have these caps, therefore the cells are going to be extremely, extremely sensitive, and we're going to have these messed up depolarizations. Okay. The first thing you have to know about tetany, there are really two signs for tetany. The first one is known as Chau-Steck sign. In Chau-Steck sign, basically, what happens is if you go and you touch the patient's facial nerve, because the facial nerve is so sensitive, and if I nip it, we're going to have a crazy depolarization, so the entire facial muscles are still going to start twitching, and the patient, when you touch his facial nerve, is going to start twitching. Okay, the second thing you can have is known as Trousseau sign. In Trousseau sign also, normally if you go and if you would put the blood pressure cuff on the patient's arm, and you pump it, and again, about after a minute, what's going to happen is the entire muscles are going to start twitching. And of course, this is caused by the fact that our nerves are extremely, extremely sensitive. Okay. Again, you just do vice versa. Again, you're also going to have the muscle pain. Instead of diarrhea, instead of the constipation, you're going to have massive diarrhea. Because again, the smooth muscles are unable to go and control it properly, therefore we're going to have diarrhea. Okay, so that's basically the symptoms of hypocalcemia. Okay, so definitely hypercalcemia and hypocalcemia can definitely be problematic. I forgot to mention also over here, you could also have very severe seizures, which could be very dangerous for the patient. So yes, hypocalcemia and hypercalcemia is going to be problematic, which is why the regulation of PTH is going to be extremely important. Okay, now let's first discuss how PTH is regulated. So normally, on the actual parathyroid cells, of course you're going to have, very important, you're going to have the calcium receptors, which are basically calcium channels, okay? And what these basically do, this is sensitive to, number one, the free calcium. Only free calcium is able to actually stimulate this channel. And what happens is when, for example, let's say calcium is going to be low into the blood. What's going to happen is that these channels are going to get excited, and as a result, the parathyroid is going to go and release PTH. Okay. In addition, if this is going to be chronically low, therefore, besides for just releasing PTH from the vesicles, we're actually even going to go to the genetics of the cell, and we're going to actually lead to the synthesis of PTH. Now, just for the board exam, you should know that PTH actually initially is referred to as PTH, pre-proparathyroid hormone. Just understand over here that in order for it to actually work, we have to have two cleavages over here in order to actually have what is known as the active PTH, okay? So again, just know we have to have two cleavages, okay? Now, once PTH is going to go and be elevated in the blood, how is this going to go and going to increase the calcium level? So, it primarily works through really two ways, but possibly three ways. The first thing obviously is going to do is going to go to the bone. Okay, now in the bone, obviously, the first thing it's going to do is going to stimulate the PTH receptor, the PTHR, which number one is GS coupled. And of course, when it stimulates it, increased protein kinase A, and we have increased protein kinase A, the first thing we're going to do is that within the bone, you actually have interstitial fluid, which is filled in calcium. And the first thing we want to do is to acutely raise calcium levels, we're going to go and we're going to release that calcium in the interstitial fluid to try increasing calcium levels, okay? But in addition, also, as PTH continues to stimulate receptor, many people think, remember, because bone has 99% of the calcium, so the best place you want it to actually, get the calcium is probably be from the bone. Now, what's very important is a lot of patients think that the osteoclasts are the one that PTH stimulates. That's actually wrong. Surprisingly, the PTH receptors are actually going to be on the osteoblast, okay? And when the PTH stimulates receptor, again, this is GS stimulatory, this is going to go and release interleukin-6. And interleukin-6 is going to stimulate the osteoclast, okay? So we eventually stimulate the osteoclast, it's just we stimulate it through the osteoblast. And of course, when the osteoclast is going to be stimulated, this is going to release all the collagenases, the proteases, and in addition, again, remember, these enzymes really work the best when the pH is going to be low. So in addition, there are a lot of different type of proton pumps over here. So in addition, and when this osteoclast is stimulated, we're going to release protons to lower the pH so these enzymes can work properly, of course, and break down the bone. And of course, when it breaks down the bone, three things are going to come out. We're going to have the phosphate, the calcium, and what calcium and phosphate sit on, which is going to be hydroxyproline. Okay. By the way, hydroxyproline again. Normally, when calcium level phosphorus are even, basically they're going to go to the bone and they go and rest on the hydroxyproline. Okay. Now, and of course, these things are going to be elevated in the blood. And of course, this is how the first way we go, and we could actually regulate our calcium level. Now, the second way we could actually regulate our calcium level is actually PTH basically working into the kidney. Okay, so the kidney, obviously, specifically in the kidney, the distal convoluted tubule as well as the collecting duct, this is really where the PTH receptors are going to be activated, okay? Now, what happens is, normally what happens is, this segment really is responsible for controlling and absorbing the calcium levels. Now, normally what happens is, if this is, let's say, a cell, on the luminal side, you basically have calcium channels, which will go and bring calcium within the cell, okay? Now, once calcium is in the cell, in order for it to be back into the blood, there are two very important channels. The first one is going to be the calcium sodium transporter, and the second one is going to be the calcium ATPase. Okay, and of course, these are going to go and it's going to be responsible for taking the calcium in the cell and then dumping them back into the bloodstream. Okay, so we're going to increase our calcium levels. Now, what PTH does is basically when it stimulates its receptors on these cells, of course, G-stimulatory is going to go, and protein kinase A is going to phosphorylate these channels. It's going to phosphorylate, number one, the sodium calcium transporter, and this is going to phosphorylate the calcium ATPases. Okay, and by phosphorylating them, we're going to increase the amount and how fast we're going to bring calcium within the blood. Therefore, the intracellular calcium levels are going to fall, and when intracellular calcium levels fall, there's going to be a greater concentration gradient, and calcium is going to rush inside the cell. Thus, we're going to absorb more calcium within the cell. Okay. In addition, PTH also has receptors on the proximal convoluted tubule. On the proximal convoluted tubule, of course, that is responsible, one of the things, I forget many things, but one of the things specifically over here is responsible to absorb phosphate. There's a phosphate sodium transporter, which basically goes and responsible for absorbing phosphate, and what PTH basically is going to do over here is going to inhibit the absorption of phosphate. Thus, we are going to push phosphate into the urine, and we're going to increase phosphate, calcium within our blood. Okay, so that's really what PTH does. In addition, the third thing what PTH does is, again, it still works on these proximal convoluted tubule cells, and after it obviously stimulates the G-stimulatory protein, the protein kinase A is going to go, and of course the kidney has a very important enzyme referred to as the alpha-1 hydroxylase. Okay, the alpha-1 hydroxylase basically its job is to take 25-dihydroxycholecalciferol to 125-dihydroxycholecalciferol. Okay, and this is basically going to be vitamin D. You see, normally, vitamin D could come into our bloodstream from, we could either have it from our diet, or we get vitamin D we could actually synthesize it. Now again, we really discussed this in the biochemistry lecture, but just to quickly review, normally UV lights basically will hit the skin and will convert 7-hydrocholesterol to a product we refer to as cholecalciferol. Okay, that is step number 1. Step number 2, cholecalciferol will go to the liver. Inside the liver, the 25-hydroxylase will convert cholecalciferol to 25-dihydroxycholecalciferol. Okay, and step 3, and this is how we make vitamin D, in the proximal convoluted tubule, the alpha-1 hydroxylase will basically go and convert 25-dihydroxycholecalciferol to 125-dihydroxycholecalciferol. And this is going to be the active vitamin D. So PTH is going to go and also stimulate the production of vitamin D within the blood. And vitamin D normally will go and do two things. The first thing it's going to do is going to go to the GI system. In the GI system, basically, it's going to go and it's going to lead to the reabsorption of calcium. Okay, and how it does this, basically, within these cells is a protein called as calbindin, which basically is responsible for, once in the cell, converting calcium to outside of the cell. So basically, if we stimulate the protein kinase A over here, we're going to stimulate the calbindin protein, which is going to rapidly take out calcium within our cell. Therefore, the intracellular calcium levels are going to fall, and when they fall, we're going to have a greater absorption. And of course, that is how we absorb calcium from our gut. Okay. In addition, vitamin D also goes in the proximal convoluted tubule, and it can stimulate the proximal convoluted tubule as well as distal convoluted tubule and the collecting duct. And first, let's talk about the distal convoluted tubule. Of course, on these cells also you're going to have vitamin D receptors. And of course, vitamin D receptors obviously are also going to stimulate the calcium-sodium channels, as well as the calcium ATPases, which is going to lead to the reabsorption of calcium within our blood. But in addition, what's different about parathyroid hormone, also on the proximal convoluted tubule cells, there's vitamin D receptors. Well, actually, really inside it's lipid soluble, but either way, it's going to stimulate the vitamin D receptors, and this is going to lead to the increase of phosphate. So, one very important distinction is PTH basically lowers the phosphate level in the blood and increases the calcium level, while vitamin D basically goes and increases the phosphate level as well as increases the vitamin D, and keeps the calcium level within the blood. And of course, the reason why we have this is because, yes, although PTH is going to be very erratic with phosphate, in order to really regulate this, obviously, we don't want to lose all our phosphate. Basically, vitamin D is going to absorb some, so we still keep the phosphate somewhat, not so low. But obviously, if you're asking me what's going to win, vitamin D or PTH, the answer is PTH is going to win. PTH, and basically the net phosphate is basically going to be decreased in these patients, even with vitamin D. Okay. And thirdly, vitamin D could also go basically to the muscle, and into the muscle on the osteoclast. Basically, there's also vitamin D receptors, and this is really only when vitamin D is really pathologically high. It can basically stimulate the osteoclast, and we're going to have breakdown of bone. Another way also to increase the level of calcium within our body. Okay. Now, and vice versa. So that is what happens when calcium levels are low. And vice versa, when calcium levels are high, for example, what's going to happen is we're not going to have this whole pathway. Therefore, we're going to have decreased PTH, decreased vitamin D. Therefore, we're going to have decreased calcium within our blood, and we're also going to low levels of calcium. In addition, also, when calcium is also very high, it stimulates, remember in the thyroid gland we talked about the C cells, the calcitonin cells, and these cells basically will release calcitonin, and calcitonin really isn't important. It's just really, for one thing, we'll discuss clinically later, but calcitonin is able to basically go and put calcium within the bones. It allows calcium to rest in bones. So when calcium levels are very high, besides for inhibiting PTH, we're also going to stimulate calcitonin, and calcitonin basically will go and it will put some calcium back into the bones, okay? And that is how we basically regulate calcium. Just remember, very important, we regulate calcium only through the free calcium over here, okay? Now, regarding diseases with the parathyroid gland, the first is going to be the hypoparathyroidism, okay? Now, in hypoparathyroidism, this means that we're going to have high levels of PTH, okay? Now, there are two technically types of hypoparathyroidisms. You can have primary hyperparathyroidism, and you can have secondary hyperparathyroidism. In primary hyperparathyroidism, first of all, understand that the most common cause for a primary hyperthyroidism is going to be a parathyroid adenoma. Okay, you have some type of ectopic adenoma within the thyroid gland that's producing intolerant amounts of PTH, and this usually about is 80% of the times, really 85% of the times, you're going to have a adenoma causing hyperparathyroidism. The second most common cause for a primary hyperthyroidism is going to be hyperplasia. Specifically, we're going to have most of the times 4-gland hyperplasia of the parathyroid gland. Again, this is about 10 to 15%, and only very rarely is 1 to really 5% can be cancers. Okay, but it's usually not cancers. Okay, and of course, in primary hyperparathyroidism, what's happening is that the parathyroid gland itself is going to release intolerant amounts of PTH due because something's forcing it to release PTH. Okay, if there's adenoma, we have forceful hyperplasia, or we have a cancer that's releasing the PTH. However, in secondary hyperparathyroidism, what happens is over here is, for whatever reason, these patients are going to have chronic low levels of calcium. And because they're going to have chronic low levels of calcium, the free calcium is going to be very low for a long time. This is going to overstimulate the parathyroid gland to release a lot of parathyroid hormone. Okay, a lot of times this happens. Let's say, for example, vitamin D deficiency. In vitamin D deficiencies, again, this could come, like we spoke about before. It could either come for, number one, a person's malnourished, he has some type of absorption problem where he cannot absorb vitamin D, or let's say he's not getting enough sunlight, so he cannot convert 7-dihydrocholesterol to cholecalciferol, or if he has chronic, really severe liver failure, then the 25-hydroxylase is not going to work properly. Or if, let's say, if his kidney, remember the kidney, very important, the kidney, even anywhere from mild to moderate kidney disease, could already lead to dysfunctional of the 1-alpha hydroxylase. So moderate kidney disease can lead to vitamin D deficiency. All those can lead to vitamin D deficiency. And of course, with vitamin D deficiency, you're going to have low calcium. When you have low calcium, you're going to stimulate the PTH a lot. Therefore, we're going to have hyperparathyroidism. Also very important. Also, kidney disease itself, even without the vitamin D problem, kidney disease itself. What happens is when we have kidney failure, what happens is obviously we're going to have low GFR. When we have low GFR, that means we're going to have low phosphate that's going to be filtered within the kidney and excreted. Therefore, when we're going to have low phosphate, then more phosphate can now bind to the free calcium, and therefore it's going to steal all the free calcium that normally is able to go and bind to the it's normally able to go and work in the tissues, and we're going to perceive that the calcium levels are going to be low. Therefore, we're going to have the secondary hyperparathyroidism. Okay. Now, regarding the symptoms of, first of all, primary hyperparathyroidism, the symptoms are going to be, well, the first thing you have to understand is that, of course, you're going to have a hypercalcemia. You're going to have a hypercalcemia because we're going to have massive breakdown of osteolysis. Increased PTH, we're going to have increased osteolysis. So we're going to break down a lot of calcium within the blood. Now, this calcium in the blood is referred to as asymptomatic calcium, okay? And this is extremely important to differentiate from other causes of hypercalcemia. Hyperparathyroidism that causes hypercalcemia is usually going to be asymptomatic. That means we're not going to have any really severe symptoms over here, okay? The symptomatic hypercalcemia, that's usually caused from some type of metastatic, diseases. For example, let's say multiple myeloma, or let's say lymphomas that basically metastasize into the bone. So we're going to have increased breakdown. In those situations, then we're going to have our symptomatic hypercalcemia with the CNS depression and all the other problems, like the acute pancreatitis and those other severe symptoms associated with hypercalcemia. Okay, but the hyperparathyroidism usually is asymptomatic. Oh, by the way, I forgot to mention over here before, there are also a couple of more diseases associated with hypercalcemia. Another thing, what happens is, remember, because we have increased calcium, anytime we have increased calcium within our blood, we have hypercalcemia, automatically we're going to have hypercalciuria. And when we have hypercalciuria, the more calcium within obviously our kidney, that means we have more predisposed to developing kidney stones. So patients with hypercalcemia could also develop kidney stones. In addition, like we mentioned before, when we're dealing with the neurofibrinogenetic diabetes insipidus, patients with hypercalcemia, because calcium interferes with the ADH within the distal convoluted tubule, what happens is that the patient could also develop a neurofibrinogenetic diabetes insipidus. Okay, so of course what happens is then they're going to go and they're going to have a massive diuresis. We're not able to absorb any water. Therefore, our blood's going to get hemoconcentrated, and when we're hemoconcentrated, this is obviously going to go and make the hypercalcemia even worse. So that you have to be very careful for these patients. Okay, and in addition, also the last thing that the calcium likes to do when it's high is likes to cause what is known as a metastatic hypercalcemia. And what happens over here is not really metastatic hypercalcemia, but really it's called as metastatic calcifications. Okay, and what happens over here is that when we have increased levels of calcium within our body, so the calcium likes to deposit in certain areas. Which areas? Right, because calcium is positive, it likes to go and deposit where areas that are going to be very alkaline. For example, any one time you want to know which areas are alkaline, just know which areas are going to have very low pH. For example, the stomach. Normally, of course, in order to make the stomach of very low pH, we have to split the bicarb from the hydrogen. Okay, so one side we're going to throw all the hydrogens, the other side we're going to have all the bicarb. So one side's going to be very alkaline, while the other side's going to be very acidic. Okay, so in those three organs, because calcium likes to go to the alkaline to try balancing it, so it's going to go to the kidney. It can build up in, let's say, the stomach, and it can build up in the lungs, and it could cause dysfunction, and it can impair those organs from functioning properly. Okay, those are other symptoms with hypercalcemia. Now, although the patients with hyperthyroidism do not have these symptoms, but they will have, they can get the kidney stones, they can get the neurofibrinogenetic diabetes insipidus, and they can get the metastatic calcifications. Okay, they can get those three things over here. Okay, and that's very important to understand over here. Okay, so that's with the hypercalcemia. Now, the other symptoms that are associated with hyperthyroidism is going to be solely caused by the increased levels of PTH. Now, when we have increased levels of PTH, of course, what's happening, and this is primarily on the bone, what's going to happen is we're going to break down bone. We're going to have so much increased osteolysis. What's going to happen is the bone. Remember, osteoclasts are macrophages within bone. Okay, that's really all they are. So if we're going to really stimulate the osteoclast, then the osteoclast eventually going to release all these inflammatory mediators, and this could lead to inflammation. So we're going to develop an osteitis. This could also go and lead to cyst formation, and of course it could lead to very weak and fragile bones. Okay, and altogether, what happens is increased level of PTH. All hyperparathyroidism leads to something known as osteitis, fibrosis cystica. Okay, and this is disease basically causes when we have high levels of PTH in our body. And of course, remember the bone, the type of cyst it likes to produce, they were initially called brown tumors because they were brown cysts. So you might also see on the exam that this is a brown tumor, brown cyst. So just know that's part of the osteitis fibrosis cystica syndrome over here. Okay. Now, also in regarding to the levels that we're going to see in the blood with hypercalcemia, so the first thing we need to know about is the calcium level, the phosphate level. That's really the most important to differentiate these two. Again, and we're also going to look at it within the urine, and we're looking at it in the blood and urine. Okay. So now in the blood, of course, we're going to have hypercalcemia. Why? Because we're going to have massive PTH on the osteoclast, which is going to lead to breakdown of calcium within the blood. Okay, so we're going to have hypercalcemia. Now, anytime we have hypercalcemia, automatically we're also going to have hypercalciuria. So therefore, the blood calcium and the blood urine is going to be high with calcium. Now, regarding the phosphate is going to be low in the blood. Why? Because, like we said before, PTH likes to go and work on distal convoluted tubule and the proximal convoluted tubule. It's going to go and it's inhibit their channels. Therefore, we're going to have low calcium levels in the blood because we're not going to be able to absorb it. And because we made a lot of calcium and we're not absorbing it, it's obviously all going to go into the urine, and we're going to have in the urine we're going to have the hyperphosphaturia, and in the blood we're going to have the hypophosphatemia. Okay. In addition, also within PTH, in addition, you could also remember we spoke about when the bone is broken down, you could have hydroxyproline, calcium, and phosphate is going to be released. So technically, because we have massive bone hemolysis over here, the hydroxyproline is going to be high. Well, not really in the blood; it really gets all filtered in the blood, but in the urine, it's going to be very high in the blood. Okay. Also, in addition, because regarding vitamin D, you could also find vitamin D high in the urine. Why? Because as well as also vitamin D is going to be very high in the blood. Why? Because PTH is going to stimulate the vitamin D production, and of course vitamin D production is going to go, and eventually it's going to increase the calcium levels even more. Again, it's going to try absorbing phosphate, but like we said before, the net absorption of phosphate is eventually still going to be low. Now, in addition, remember, because vitamin D and PTH are going to work on the kidney, of course, that's going to increase the levels of cyclic AMP. It's going to increase the levels of protein kinase A, and of course, when we have so much increased levels of cyclic AMP due to PTH and vitamin D, so in the blood, in the urine, what's going to happen is we're going to have increased levels of cyclic AMP as well. Okay, so that is really going to be your findings within a patient with hyperparathyroidism. Okay, now regarding with the secondary hyperparathyroidism, what happens is the exact opposite. What happens is we have a hypocalcemia due to some type of secondary disease that's forced to us, and it's forcing the parathyroid gland to release PTH because we have to try raising the calcium levels. And although we still have increased PTH, we still cannot get that calcium level high. That's why we have a disease over here. Okay. Now, to differentiate from these levels over here, well, first of all, we'll talk about the symptoms. The symptoms with of course, hyperparathyroidism. Again, we're going to have the same symptoms over here with the regarding with osteitis fibrosis cystica. However, regarding the hypocalcemia, we don't have hypocalcemia. Over here, we're going to have symptoms of hypocalcemia. Okay, over here, symptoms of hypocalcemia. So we're going to have tetany. We could have CNS problems. Of course, we could have the diarrhea, etc. So keep that in mind for over here. Okay. Now, very important. Regarding the laboratory levels are going to be within the secondary hyperparathyroidism. So really the only thing that you're going to have to change over here, well, of course, depending on vitamin D can either be high or low over here, obviously. But really, this is really the only thing important about the values you're going to see in the board exam. And of course, the only thing different is with this entire diagram is that the calcium within the blood is going to be low in both situations. Okay, the phosphate is going to be the same usually because the PTH is still going to catch phosphate. However, the calcium within the blood is going to be low in these situations. Okay. Now, let's say the patient, for whatever reason, Mrs. Johnson comes into our office. She's doing a physical, exam, and we find out that on the labs she has hypercalcemia. Now, for our, examples and purposes right now, she's going to have a hypercalcemia that is going to be asymptomatic. She's not going to have symptoms. Obviously, if she had symptoms, our work will be much different. I wouldn't think hyperparathyroidism. I would think more malignancies, multiple myeloma, leukemias, metastatic breast cancer, and those type of things. But right now, we're going to assume that it's asymptomatic. So the first thing you want to do, again, the most common cause for hyperparathyroidism is by far going to be hyperparathyroidism, primary hyperparathyroidism. So obviously, we're going to get a PTH level, and we're going to see if this is high or low. Okay. Now, before we discuss if this is hyperparathyroidism, let's first discuss the other causes of hypercalcemia. Now, let's say if the parathyroid hormones, let's say, is going to be normal. Let's say it's going to be negative. Let's say it's normal levels. Other causes of hypercalcemia can be hypercalcemia due to any situation that really immobilizes the patient. You see, when a patient's immobilized, let's say, a person's in an old age home, his legs are always on the bed, he's never, up and putting stress on his bones. What happens is the rule with bones is, if you don't use bones, they're going to break down. And people who are just unfortunately in old age home beds, what's going to happen is that their bones are going to start breaking. When they start to break, they release calcium, and of course, patients may have a hypercalcemia. Okay, so the first thing you want to do is you want to make sure if the patient is not immobilized. Other things that can cause hypercalcemia are drugs. What drugs like to cause it? The first ones are diuretics, can cause a hypercalcemia. Drugs like lithium can cause a hypercalcemia. T3 and T4 replacements can cause a hypercalcemia. Why? Because of course they could break down bone. That's why, remember, by thyroid, we don't want to really treat with T3 for so long because this can go and lead to osteoporosis and other bone problems within these older patients. Okay. Other causes for hypercalcemia could be, for example, hyperparathyroidism, like we discussed before. When the thyroid levels are extremely high, T3 and T4 could actually be a catabolic hormone. They actually have a catabolic. And when they act catabolic, this can lead to the bone breakdown. Okay, and of course, when the bone breaks down, we're going to have hypercalcemia. Okay, other causes of hypercalcemia, we can have what is known as a certain cancers, specifically lung cancers, oat cell cancers, it's referred to as. Okay, these oat cell carcinomas, what happens is they release a certain molecule which is referred to as PTH-like molecule. PTH-like molecule. And what this is, it looks exactly like PTH. It doesn't come up on the same level as PTH. They come up differently, but it works like PTH. It looks like PTH. And what happens is it's able to go and activate all PTH receptors around the body. So although we will go and so for in other words, it's really going to induce like a hyperparathyroidism. Although we're not going to have high levels of PTH, we're obviously going to have low levels of PTH because we're going to inhibit because of hypercalcemia. Okay, and of course this is a cancer, and obviously we're going to have symptoms of hypercalcemia, and you need to be treating this very aggressively. This is a very dangerous cancer. Well, again, we'll discuss this in the respiratory section. Okay, other causes for high levels of calcium, patients could be vitamin D toxicity. They go OD on vitamin D. Of course, this leads to increased levels of calcium because obviously, like we said before, this could actually go and lead to osteoclastic breakdown as well. Okay, other causes of hypercalcemia. You can have a very important disease. It's referred to as hypercalciuric, or what's really known as, familial hypocalciuric hypercalcemia. Okay, and what happens in these patients is that these patients normally we have, like when we spoke about before about the osmoreceptors, that during pregnancy they basically reset to a different level to basically regulate to try increasing the plasma volume with the pregnancy. Well, in these patients they have a similar event that's happening. Normally our body, for example, has our calcium receptors set at, let's say, 100. Okay, what happens in these patients is these patients have a pathological, not really pathological, it's nothing really, it's not really dangerous, but their reset calcium button is really, let's say, like 120. Okay, and because they have 120, their reset is, so their body's not going to perceive of hypercalcemia until it's over 120. And although 120 is over for us, these patients are not going to have, perceive this as anything, and therefore they're going to randomly have a high level of calcium within their blood. Okay, just note over here, this is really honestly benign. The treatment is going to be nothing. You don't do anything for these patients. It's not a dangerous disease. Okay, so these are really the causes of hypercalcemia that you should know. Now, very, very important. Now, now let's go back to actual PTH. Now, once we have high levels of PTH, what are they going to do? Then we're going to go and we're going to do our X-ray. We're going to see what it is. Is this an adenoma? Is this going to be a hyperplasia? Or is this a cancer we're going to obviously only see after we biopsy this, okay? And of course, if regardless of what it is, we're going to do surgery. Now, actually, that's just debatable. Regarding surgery over here, now surgery is actually questionable, okay? Surgery is only for patients who are young patients. So surgery, in order to be a surgery, if number one, you're young, even if you're asymptomatic, or you're symptomatic whether you're young or old, okay? If you're any of these, then you're going to require surgery. So when you're not going to require surgery, for example, if you're an 80-year-old with primary hyperparathyroidism with a parathyroid adenoma and you're asymptomatic, we're not going to do surgery because the likelihood that you're going to die from the surgery is a lot greater than you're actually going to die from this hyperparathyroidism, okay? So that is the surgery. Now, very, 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 very important. After the surgery, you have to be aware of a very dangerous complication, and therefore you have to watch these patients very carefully, okay? There's a syndrome known as hungry bone syndrome, okay? Hungry bone syndrome, also known as HBS, is a syndrome caused by, remember, because we have chronic levels of hyperparathyroid hormone, what's going to happen is that the bones were drained from all the calcium within their body. Bones get drained of calcium, and they really get really depleted. Okay, and now once we remove the parathyroid hormone, the bones are going to take, like, for example, vengeance on the body. And it's going to take back all the calcium that we jacked and we stole from it. Therefore, we're going to really deplete our body from calcium, and we develop a very severe hypocalcemia. So you have to be very careful with these patients after surgery that they don't develop hungry bone syndrome. Okay? Now, let's discuss the treatment of hypercalcemia now that, let's say, a patient is going to be symptomatic, okay? Again, it's usually not going to be PTH, but it's usually going to be, let's say, metastatic cancer, but the treatment for hypercalcemia that is going to be symptomatic. What are you going to do? So the first thing, obviously, is to make sure stable your patient, make sure his vitals are stable, blah, 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 all that stuff. Now, the first thing you want to do with this patient is, because calcium is really increasing to the blood, and it's causing symptoms over here like seizures, CNS depression, what's going to happen is that if we don't handle this right away, the patient, God forbid, die. So the first thing you want to do is you want to give them fluids, okay? Why are we giving them fluids? For three reasons. The most important reason is because as we sort of fluid them, as we give them fluids, we're basically going to be dilating their serum. When we dilate their serum, of course, their calcium gets dilated, therefore calcium levels go down. Second reason why we're giving them fluids is because hypercalcemia induces diabetes insipidus. When we have diabetes insipidus, this goes and leads to more water getting depletion, they develop dehydration, they develop hypotension, and of course, and if they're dehydrated, this concentrates the calcium even more, which leads to even more hypercalcemia. So, second thing is that's why we're going to hydrate these patients. The third reason why we hydrate these patients is because these patients also to remember, of course, the more fluid we have in our body, the more GFR we're going to have. And the more GFR within the kidney, this is going to obviously lead to more calcium kishing out of the person's body. Okay? So that's why the first thing to do is to hydrate these patients. That's the most important thing to do. Stabilize, then hydrate them. Okay? Now, regarding, now once we hydrate these patients, of course, hydrating is good really for the acute setting. Now, for the chronic setting, we have to give the bisphosphates. Okay? The bisphosphates basically go, like we said before, basically bind to free calcium, thus reducing levels of calcium within our body. Now, unfortunately, bisphosphates really only take about 48 hours to even start working, so they only lower the calcium levels, chronically. So this will be good if a patient has really a stable, if we're able to stable the patient's hypercalcemia with fluids, then we'll give the bisphosphates. If, however, the patient still has life-threatening seizures, he's really unstable with hypercalcemia, then what you have to give them is you're going to have to give them calcitonin. Like we discussed before, calcitonin basically goes and it forces calcium into bones to obviously lower the calcium level within the body. Okay? And of course, in the chronic setting, obviously if the patient's already stable, then we obviously we can treat the underlying disease for whatever reason. Let's see if it's cancer, whether it's hyperparathyroidism, whatever it is, vitamin D toxicity. Once we go and we stable the calcium levels, then we could treat the patient. Okay. Now regarding the secondary hyperparathyroidism, again, the causes are the causes. Basically, just the difference is the hypocalcemia. We're not getting the hyper, we get the hypo, so we can develop symptoms of tetany. Now the treatment with hypocalcemia obviously is just to give, well, it depends. If they have very severe symptoms, let's write this over here. If patients with hypocalcemia have severe symptoms, what we're going to do is we have to, number one, we have to give IV calcium gluconate, okay? Of course, to really very quickly raise the calcium levels in the blood. If the patient is pretty much stable and we don't need to do IV, then we can just give them oral calcium pills, and we can go and give them vitamin D if they need it. Again, like we said, a lot of causes of secondary hyperparathyroidism can be caused by vitamin deficiencies. So if we give vitamin D, this could really be good for these patients. Okay. The patient is going to develop a secondary hyperparathyroidism due to renal failure. What you're going to have to do in these patients, of course, besides for treating them, obviously you're going to have to give the phosphate binders, okay? Because remember, if we have two high levels of phosphate within our blood, this is going to bind all the free calcium. So we give phosphate binders to go and to get rid of the phosphate, so our phosphate becomes normal levels. Because remember, if we have renal failure, we have increased GFR, which means we're going to build up phosphate. So we give phosphate binders to basically kiss all the phosphate, okay? And that is basically the hyperparathyroidism. Now, one more quick thing about the hypoparathyroidisms. Just know primary hyperparathyroidism, again, obviously it means we have no PTH. This obviously is going to be coming because usually let's say did thyroid cancer or let's say a thyroidectomy. So usually we end up removing the parathyroid glands, or we treated, let's say, a parathyroid adenoma. We had to remove the parathyroid gland or whatever it is. The parathyroid is not there, so we're not going to have PTH. Okay, what we're going to do for these patients, we're going to give them oral calcium and basically give them the phosphate binders as well with these patients. Okay, and again, regarding the secondary hyperparathyroidism, again, this is usually caused by diseases like, for example, vitamin D toxicity or anything that could really increase the calcium levels high, which is going to inhibit the parathyroid from working. And of course, just treat underlying disease, and you obviously will get your thyroid levels back to normal. Okay.